All right, we're live. We're live. All right, most of you guys who are lucky enough to follow me wherever you follow me, you probably just see me in real life at the gym, but you've seen this guy. We've talked before. Is my cousin, Dr. Justin Grant, and we are back to talk about something that we have. Well, we have similar perspectives, but he can bring other insights, pretty strong insights into your life around a specific topic that I have seen um, over the years be a very common deal people need to deal with. It is back health, back pain, when, what, surgery, what's available, what kind of new research is out there. I'm going to let him talk about his expertise and what he's doing, and he's working with some pretty cutting edge stuff that is it's really cool. I was looking at it pretty detailed yesterday, preparing for our little podcast, if you will. And it's exciting. It's exciting. It's not available to everybody, but people that do have chronic back pain, understanding what's out there, what's available, being able to navigate and get back to one thing that him and his partner talk about a lot is, getting back to quality of life, mobility, not just pain management, but getting to a place where, you're thriving, and surgical intervention might be a part of that. And Dr. Grant, my cousin Justin, um, he works with directly with the surgeon, and I'm gonna let him explain what he does in the back health space. And we're just gonna kind of go back and forth talking about things that I've seen in the gym, stuff that's come up with members in my circle, and then also his experiences and his evolution in all this topic around back pain. I think you guys are going to get some pretty good value and insights out of this, at the very least, some good talking points, maybe to talk with your doctor, your physical therapist, your chiropractor, and so forth, and just options, right? What we're saying here isn't like, go do this right away. I mean, obviously, consult with who you work with on these things. Um, and yeah. So, Justin, what are you doing these days when it comes to this stuff? Because it's pretty cool. Like, that company is pretty rad. Modus is the
Three spine.
three spine,
Yep.
but Modus is the one that makes that implant.
So Modus is technically the name of the implant.
Got you. Okay, that all right. That makes sense.
Yep.
Cool.
And actually, so like that's some of the real exciting, sexy stuff. Definitely would love to get to, but maybe this would be a good time to drop the idea. I think you should have Dr. Sladicky himself on this podcast. Maybe as a follow-up to this. I know he would love to. Could have both of us on here, have him on here, whatever.
Cool thing about
So
this software is we can all be on here.
yeah.
Just that is Justin's partner, so they work together on spine care.
Yep.
So
Okay, so well, first let me tell you, I guess, a little bit about myself. So my background, I want to actually start with is in athletics, and I think it's really important to lay that foundation because there's a lot of people in medicine who are not very athletically inclined. They just don't seem to think that way, and unfortunately, even in the world of sports medicine, a lot of sports doctors just don't have that personal experience, and then especially in the surgical world, to become a surgeon, most surgeons. I say most, not all, but are more academically inclined. And that's great. We need that, but it's just missing kind of that piece to marry to the athletic side of the world. And I think that's with that foundation that's built the opportunity for me to kind of slide into the niche that been sliding into. Um, on top of that, building on that foundation, I wrestled in college, suffered from some injuries on my own. And then I went from there into medical school. It's an osteopathic program, so I'm a DO. A cool thing about osteopathic schools is we do get a little bit more education on musculoskeletal health. From there, went into family medicine residency, where the particular residency I went to is a very strong internal medicine type of residency. It's not internal medicine, it's family medicine, but we have a lot of strong inpatient care, a lot of strong medicine. And that's very important to where I'm going with this because when you have the athletic background and then you start to add more of the academic medicine on top of it. And then I did a sports medicine fellowship from there. And in the sports medicine, it was your traditional sports medicine and dealing with your, you know, tendonitis or ACL injuries, blown shoulders, etc. We did a little bit of spine care in the sports medicine fellowship, but most of that actually came after I graduated and I started on my own. The practice that I have now, about halfway through my fellowship, still wasn't sure where I was going to go. Hadn't really got signed a contract with anyone yet. And then out here in rural Meeker, Colorado, they were in talks with a great spine surgeon, ended up being a great friend, Dr. Devin. Dr. Devin wanted to come operate out here, but he really wanted a non-operative person on the team as boots on the ground before he would agree to come here. So then the hospital reached out to me, said, "Hey, I understand you're in the sports medicine program," and they knew about me actually because my brother lives here already. Trevor, he had been here for a year. Um, they reached out to me, said, "This is what we want to do." So that sounds great. So I came out here for the first year, did more traditional family medicine, and then tried to build the spine program. I have since transitioned away from family medicine. Now I only do sports and spine. Um, with that focus in the spine world, I first assist on all of our spine surgeries, and that's provided a great opportunity for me to really understand spine surgery, the way spine surgeons think, at least the ones that I work with. Um, and it's allowed us to build the relationship where we have brought these two worlds together, the athletic world and maintaining motion, etc., and bring it more to the spine surgery side. Dr. Devin unfortunately passed away in a plane crash after we'd been working together a couple of years. Um, his mentee, I guess you could say would be Dr. Alex Saladicki, another brilliant spine surgeon, has become a really close friend of mine. Um, he ended up taking over Dr. Devin's practice, and Dr. Devin, Dr. Saladicki, and then one of their friends, Dr. Hodges. I think there's a couple others who are involved, but they've been really the key players in developing this new um, technology. So when it comes to spine surgery, you traditionally are going to get a spine fusion, and like we've talked before, spine fusions lead to loss of mobility, and they can often help with pain, and oftentimes they really do help with pain, at least for the short while. But then, as we can get into a little bit later, they lead to all kinds of other problems. So this other um, implant, other possibility for a lot of people is going to be out there, and there's already some of that. There's an anterior lumbar disc replacement, but there's so few people who would be candidates for that. Um, but yeah, so that's all a little bit later thing to talk about. That's providing my background and how I've come to where I'm at.
Right.
Um, so yeah, from there with that kind of background, I guess what do you want to talk about first, cuz?
So let's talk about Jay. What do you want? Sorry, fam.
I understand.
Let's just sit over here and be quiet. Everybody
Kiddos.
knows I'm battling the minions. So
Yeah.
let's talk about progression, maybe of acute spine injury. Right. Obviously, there's situations in which you need immediate medical care. Right. So we have that. There we go. You jump in. Wait, person gets in a car wreck, falls off a ladder. These kinds of deals. This is a very acute spine injury. Okay, you go in, you get some imaging, but you still, you might have some radiating nerve pain down. That I'm going to assume that the bulk of our conversation is probably going to involve the lumbar spine. And that's where I see most issues. I don't see a lot of thoracic and cervical issues in my world, other than the handstand push-up crowd. That's another conversation. But so you have the acute, very acute. That, depending on what took place there are folks that tend to live with chronic back pain after that. And it seems that you go, you get some imaging, they tell you, okay, probably meet with a surgeon or whatnot, depending on the scope of what the imaging looks like. Let's try non-surgical. I have noticed that a lot more surgeons are going non-surgical first, probably
Hmm.
depending on the case. I would imagine it's a case by case basis, but it seems so much in society that a lot of times it's what quote unquote bulging disc. Now, where is the bulge? Is it anterior, posterior? Is it pushing in, pushing out? Like, what is the bulge? I'm willing to bet that dictates, you know, care. But it does seem in the folks that I have been around over the years, acute imaging, follow up spine surgeon, probably physical therapy, rest, recovery, and then months, maybe years later, you have this potential chronic issue. Would that be an accurate assessment of potentially a timeline? I mean, it's kind of what I've witnessed, similar to my own acute injury that translated into me dealing with chronic lumbar pain in a major
Hmm.
way, which is now resolved at this juncture of my life 100%. So you have those. In your mind, when you are taking somebody, when somebody's going through this, what are maybe your benchmarks? What are you looking for in pain resolution? Obviously, pain resolution and pain tolerance are different from individual to individual. Some folks can tolerate a bunch of pain and live a happy, healthy life. Some folks can't tolerate any pain. I mean, it's just a very personal thing, right? What are you looking at maybe in benchmarks, imaging? What kind of physical therapy slash training, maybe protocol timelines are you giving things to resolve and looking for as people are taking steps to hopefully reconcile a chronic issue?
Hmm.
Obviously, chronic issue that's acute. You can also have chronic issue develop from living an inactive life, sitting down at a desk in life all the time, not doing any sort of blood flow, movement, mobility, strength training, and you start to atrophy as you age, as you age. And with that, facets can start moving, discs can start getting dried up as we age. You're not hydrating, driving blood flow, water, and so forth into these. So that's also an issue. I've seen the inactive person start, they come into the gym their first time in, 15 years and they're like, oh, I got chronic back pain. Well, you got no ass either. You sit on it all day. Like, I do believe dormant ass syndrome is a real thing and a big contributor to a lot of stuff. So, me just dumping that there. What are you looking for working with a patient and maybe some advice, somebody trying to navigate this in those scenarios? First
Hmm.
steps, so forth.
Yeah. So you just gave me a lot to unpack. Um,
Now I'll sit here and
let's
drink and
start with, say what?
I said, now I'll sit here and drink and listen.
Oh, that's fair. Okay. So let's start with just from the beginning. Let's talk about a back injury. And I agree. For the sake of conversation, let's stick with just the lumbar spine. The cervical spine, thoracic spine, they're completely different topics that are kind of similar, but we could talk about those later. So let's just talk about the low back. Okay. Let's take an injury. Someone falls off a ladder, gets in a car wreck, something like that. There's very clear indications in those scenarios for emergent surgery.
Right.
Um, those indications are injury to the nervous system. So down there, you're going to be injuring the cauda nerves, or in significant instability that will lead to a nerve injury. That's really it. Okay, those are the indications. If you have a spinous process fracture by itself, that's not so. Well, let me kind of give a really brief breakdown of the anatomy. Okay, so let's think about the one of the purposes of the spine is to provide a protective tunnel for the electric cords that go from the main computer to the rest of the body. If you damage those electric cords, that connection doesn't work, and then obviously you lose function. Okay, so the tunnel, anything that is going to damage the integrity of that tunnel. So then you start getting something where you're going to compress or just crush or it tears apart. Those kinds of instability fractures, those would end up needing to be addressed on a more urgent basis. Not all of them get surgery, most of them do. If you have those cables, those nerves being crushed, then you get surgery. If you have a piece of that tunnel, such as the spinous process, let's imagine you're looking at the back of it here, and you have this fin coming out. That's the spinous process. You snap that by itself, and that you don't get surgery for that, and that's not going to by itself cause chronic pain. Okay, most of the time. Same thing, transverse processes. So you got the thing that's coming off here. Those little things aren't likely going to require surgery. So that's in the acute phase. In the chronic phase, there is no one black and white like this is the magic answer. I should also preface that nothing I'm about to say or have said should count as medical advice. Definitely go talk to your doctor about it. Okay, I'm not sitting here as your physician, or anyone listening. Um, but it's very individualized, and so many things go into that equation. Okay, so most people with no treatment after let's call it a non-structural back injury, will get better on their own with time. Okay. Most people. Things that help that. Appropriate rehab helps with that. Sometimes injections help, not because you're fixing anything with injections, but you can mask enough pain to help them move a little bit. Um, we can get into why injections can be helpful here in a little bit, but when it comes to whether or not you should have surgery or not, most people will start, just like you said, down the non-operative route. Well, they'll see a surgeon. Yeah, let's go do some physical therapy. Let's try some of these things. And that's because, like I just said, most people will get better if given enough time. The other thing that I find the medical community often puts their own foot in their mouth and creates their own problems is we help a patient or we teach patients to catastrophize their problems or catastrophize their image findings. Okay. I have to see if I can find the study. I quote it all the time to patients. But essentially, if we took 100 patients or 100 people off of the street over the age of 30 with no back pain and no history of back pain, that's the key word, no current back pain and no history of back pain. We MRI'd all their backs. More than 50% have bulging discs and degenerative disc disease. Okay. So
I've heard that.
whenever I hear people come into my clinic and they say, I'm here to see you because I have a bad back. I've gotten to the point now where I stop them after that sentence every single time and say, I don't want you to ever say that again. You don't have a bad back. I don't care what the imaging looks like. You have a back. Let's start with that. Okay. And I tell them about that study. Remember, none of those people had back pain at all. The other thing, surgery for back pain, if that's the primary concern, very rarely works. Remember what I said in the emergent setting, why surgery is indicated. It's because you're compressing, damaging, pulling, stretching, etc., the cords that are providing the input to the brain and the output from the brain. The same thing's true in the chronic scenario. The spine surgeries that tend to be the most successful revolve around decompressing things that are pressing on those nerves. A bulging disc. If you have someone with a big old bulge out of the disc, 80% of those people at a year, the body either dissolves or reabsorbs enough of that disc and kind of scars it down to where it's not pushing on nerves anymore. When people have the acute disc bulge, usually that pain is just in the acute phase of either tearing the annulus or as that starts to bulge or it tears, some of the fluid from inside the disc can kind of squirt out, if you will. I'm oversimplifying it, and
Really?
cause almost like a chemical burn to the nerve. And oftentimes they'll get a bulging disc and they have radiating pain down their leg that sounds a lot like a nerve's being compressed. We get imaging and it's clearly not being compressed, but you can see on there that the annulus has been torn. Those patients, the things that actually work the best to help them move are anti-inflammatories and movement, nerve glides, keep everything movement. Um, real quick, nerve glides is simply think of it as an active form of stretching that helps the nerves slide in and out of the spinal canal.
I've had a lot of people
They're
do that.
not a static thing. It's supposed to move. So we give those people time and they usually get better. The physical therapy helps with that as well because oftentimes people then, out of the anxiety from the pain, it can be very painful, and then they find certain movements aggravate the pain, so they become anxious. And I think that by itself starts to set up a lot of chronic pain problems because then they aren't moving, and because the anticipation of the pain from a certain movement prevents them from doing that, and then that starts to set up its own problems.
Mhm.
There's also the brain component to it. When we are anticipating something and we become anxious about something, there's plenty of studies that show the anxiousness or anxiety associated with pain actually exacerbates the pain. So if you can help someone calm down, make it less of a big deal in their own mind, then the pain becomes less severe. Um, think of the pain around this as the alarm bells going off in the brain that something's wrong. But now we start thinking something's constantly wrong. The alarm bells just get louder and louder. So that's a component to this chronic pain scenario. Um, am I answering questions so far?
Oh yeah. No, I mean this is understanding the psychological component to pain is vital in navigating chronic pain.
Mm-hmm.
You touched some key points there that if you believe it's going to hurt, chances are it's going to hurt. And I can
Yep.
attest to this in my own recovery of my back injury that I had. So,
Mm-hmm.
I agree wholeheartedly what you're saying. Nerve flossing, nerve movement helped me tremendously. Uh,
Mm-hmm.
Movement in general, the right kind of movement, growing
Mm-hmm.
up a little bit, training the right ways to help my imbalances.
Mm-hmm.
And we can get into the training and performance side of things later. But no, the thing is, people don't know where to start, right? They have chronic pain. They end up, I mean, the drug addiction with pain management is an absolute shit show these days.
Mm-hmm.
Absolute disgusting.
Well,
Um,
let's talk about that for a second. So the drug addiction, it started because of medicine. Um, and I think it's because we fundamentally made a bad decision and wanting to more aggressively treat pain. You know what? That sounds great on the surface. Like that sounds um, like we're being kinder to the patients, that we're being more loving to our patients because we care about your pain.
mhm.
And in a sense, yeah, we care because that affects their quality of life, ability to move, independence, etc. But when we make it too important, it does become too important. Um,
Well,
and into effect where we literally make it worse. So let's talk about narcotics for a sec. So in my practice, I very rarely ever prescribe narcotics anymore, ever. In fact, it's pretty much just for post-operative pain. Um, reasons why are, imagine, so it works very similar to alcohol. You go 6 months, no alcohol, you have one beer, you're gonna get really buzzed, feel really good off the one beer, right? You drink 2 or 3 beers every day, you're not gonna get buzzed off of a beer. And then the reason for that is, again, oversimplifying it, but you think about it in the brain, you have receptors that the alcohol binds to. Okay. Um, Opiates work the same way for pain. So in our brain, all pain happens in the brain. Sure, I can cut my finger. The mechanism for the pain happened down here, but if I can block the center of the brain that is supposed to interpret that, I won't feel any pain. Okay, so it all happens up here. The opiate receptors are part of those pain receptors. If we constantly bind them to dull the pain, over time, and it's actually only about 2 weeks, the brain starts to think that, hey, I don't have my receptors out there. I'm not feeling what I normally feel, so I'm going to grow more receptors. So now instead of having one pain receptor, I have two. Now the patient feels the pain again. Now we bind both receptors.
yeah, you increase.
Eventually, we have 100 more receptors, and they're on these huge amounts of narcotics. And we have created that problem as the medical community because now we have to find some way to get them off of that because they're having all the other complications from the narcotics. But the problem is we now remove those narcotics. they have all these extra pain receptors out there, and they're 10 times more sensitive to pain than any narcotic naive person like you or myself.
That's an
And so
interesting
we
understanding.
literally create
Never thought of it that way.
people, we literally create people with much lower pain tolerances. They just physiologically can't handle a, a noxious stimuli. We call it hyperalgesia. They're just much more sensitive to it. So
Hmm.
that's the narcotic problem. And we also
Interesting.
know now, go ahead.
I was just gonna say it's. I didn't know that. That's interesting that there's an actual physiological adjustment to the body that takes place from overusing pain meds.
Hmm.
That in turn gets you more pain receptors, which you come off of them, you're in more pain.
Yep. Yep. And
Right?
I've had lots of patients like that. It's very difficult, and I feel for those patients. Um, it's tough. It's tough. And that's why from the very beginning, I have lots of patients in my practice with chronic pain, but they've learned right away that I don't do that. We won't do it because I believe we're making your problem worse. We have to find the problems and address those. And in the meantime, we figure out how for you to mentally deal with your pain. We do a lot of cognitive behavioral therapy type sessions in my clinic. We do a lot of mental contrasting, lots of coaching them through it, um, to get to a point where we can fix their problem before we start ramping up the narcotics. Let's go back to the surgery thing. We know that patients who are on large amounts of narcotics, they just don't get better after surgery. We can fix the problem, and it seems counterintuitive, right? It's like, so we clearly see on here you have three nerves just being crushed. So if I go in there and I decompress those nerves, you should get better, right? Well, we now have lots of evidence to show that many of those patients who have that physical problem that we can see that matches their pain perfectly, but they're on these huge amounts of narcotics, we do the surgery and they don't get better. They don't. The ones who do get better aren't on those narcotics, or they're on very low doses of them. So if you have someone listening to this and they're like, man, that's me, I'm on these huge amounts of narcotics, I don't want that person, I don't want you to lose hope. We also now know that if we can help you bring those narcotics down, make you less sensitive to pain over time, it is a very difficult road, but it's one that can be traveled, and lots of my patients have traveled it. You then get surgery, you do get better. So
That's
think
awesome.
about that.
I've never heard it put in those terms in that situation, and it does make sense to me. When, say, for instance, my Cassie, she's worked with a lot of people in the pain space. She's also in your boat. Doesn't believe in the narcotics, and like she worked in a pain clinic for a while. It was miserable. So, understanding what these drugs do, the addiction to them, because of this, we also have a society that wants the easy fix.
Hmm.
Because what you're talking about is hard work,
Yeah.
but it has a much higher success outcome. And I am grateful that the majority of people that are going to listen to this understand hard work and also have no interest in the easy fix. They want the good fix, right? They want
Hmm.
the, the, the proper outcome here.
Hmm.
So,
And I think that touches a lot on the mindset too going into it. Um, there was a study done. I will see if I can find it. It was done. If you're familiar with the short grit scale by Angela Duckworth, so basically it's a questionnaire. I think it's 8 questions long, and it correlates really really well with someone's ability um, to persevere. Okay. That single score has been associated with all kinds of different great outcomes. Um, they've applied it to people going into different, like very difficult surgical residencies, different career paths, people overcoming injuries, associated with people with chronic pain. They did this surgery on athletes who needed ACL repairs. People who had a high grit score, aka they had a better ability to persevere in the face of adversity, or distraction. So adversity and distraction both take away from your ability to persevere. Those athletes were much more likely to get back to full competition. Okay. You can apply this to anyone of basically any age as long as they're able to understand the questions. Um, we're going to be doing a study to see if how well it correlates with our spine surgery outcomes and our chronic pain patient outcomes, their ability to bring down their narcotics, their ability to recover from the surgery, complication rates, etc. Not because we want to just see like, are you mentally tough, but because from there, based on a lot of Angela Duckworth's work, you can literally teach somebody and coach somebody to become grittier, to become tougher. Um, and so we want to see one, does that truly correlate with spine surgeries? Because it seems to correlate in all these other areas. And then from there, too, how do we develop a way to help these patients improve their mental resilience to pain? Um,
I'm
because I
gonna
do believe so many people have become um, so hypersensitive to pain that that is a bigger obstacle to them getting back to their quality of life than the problem we see on their MRI.
yeah, yeah.
Let me give you two contrasting examples. I had one patient who fired me, by the way, um, who I won't give any names because there's
Okay.
people in town who will very quickly figure out who this is if I give too much information. But he, when I came into the room, was like writhing in pain and freaking out. And I was like, dude, like, crap, what's going on with this guy? We rushed him through the process, got him the MRI. He did have a disc bulge that was touching a nerve, but it matched perfectly where he was describing his pain. Okay. And he's one of the first patients that I really tried to coach towards not making the pain so important, not catastrophizing it. I obviously didn't do that very well because he fired me. Um, but then it's funny. Later that day, I had another patient, 70-something-year-old lady, lives on a ranch by herself, still takes care of the entire ranch by herself. When I looked at her MRI, I truly didn't understand how she even walked. And I compare those two things. And it really drove home the point that at the end of the day, we treat people, we don't treat pictures. This lady's back didn't look like that overnight. She's probably been living like that for 15 years. Interestingly, what else is on the MRI that a lot of people don't talk about? You can see the quality of the muscles. She's in her 70s. She had muscles that looked healthier and denser than most 30-year-old MRIs I get because she's kept herself moving, active. The guy who fired me, he has what I call wagyu spine.
Yeah.
So you take a wagyu beef, like a steak, all riddled with fat. That's what his muscles look like. And I think that that really correlates. One is the I have found that the amount of sarcopenia or the fatty infiltrates in someone's muscles on MRI, I've been finding them to strongly correlate with one, someone's pain tolerance, and two, if they're going to succeed or not. Now, I don't think that the muscle itself is causing the pain, but I think it's representative of a bigger picture, like you alluded to earlier, the lack of movement, the fact that everything is just weak. Weak muscles can't support a spine. Also, every one of those people I've noticed, they have very tight hips. I can barely log roll their hips. That all correlates very well to the chronic pain thing. But then to ask that person, and this is where a lot of doctors just get frustrated. Like, yeah, here's your script for your pain meds. Go away, because it gets very hard, very hard. Um, though asking that patient to take physical therapy seriously or to take movement seriously when they just can't get over the fact that, well, when I move, it hurts. Well, yeah, but what hurts and why does it hurt? Um, you had mentioned earlier, actually, I don't remember if you said this before we actually started recording or not, but the person who says back muscle soreness is my pain, like in trying to get them to understand the difference. A lot of my patients, so here right there in the clinic room, in the office, I'll have them do a chair to stand test for 60 seconds. Um, and then I have patients do that. They're going from no activity to we're just going to do that 60 seconds, one time a day, every day until you see me later. You're going to see me in 2 weeks. Most people quit doing that because they say it destroyed my back and it destroyed my quads. and my butt, I can like barely sit, like, and it hurts too much. What you're describing is muscle pain, muscle soreness, because your muscles are broken down, and trying to help people understand the difference. Those who have been able to help understand the difference, and we can reframe what it means, because remember, we've made pain so important that pain's always bad. So they think it hurts, so my alarm bells are going off, so I should avoid that. You can help them learn otherwise. They start learning the difference, and now they're starting to improve. So I think that when it comes to a lot of patients with chronic back pain, that's one of the most important hurdles to overcome, is helping them redefine what is appropriate pain and what is just being uncomfortable or sore, etc. Or what's the appropriate amount of pain to be leaning into. Um, I got into I don't want to say a debate, but I was listening to this mastermind in the chat box. He was the guy in the call was talking about nutrition and exercise, and he said we need to always avoid pain, and then it lit off a firestorm of debates in the
He's just trying to get
my
clicks.
thought too. Lit off a firestorm of debates in the chat box, and I just put in there that I think that in my practice there's good pain, there's bad pain, and I think it's more nuanced than that. You need to help people learn to overcome some kind of pain. And another guy put on there, no, you're wrong. All pain is bad. Signed, sports doc. So there's another sportsman doc in there. Like, okay, I'm not going to sit here and argue on a chat box. Um, but anyways, I think that's the whole problem in medicine.
Signed
We
him.
have, because we've made pain the sixth vital sign or fifth vital sign. That happened in 1996, and it wasn't until like 2017 that we started to try and remove pain as a vital sign. We have made that so important, and it's important to make pain zero. So we have created this culture and this mindset that any pain is bad. And so it goes back to earlier when I talked about how we have made pain too important. We've demonized pain, and it doesn't have to be demonized. It's part of life. If you're feeling pain, you are alive, number one. Number two, anyone who's ever accomplished something ever in their life knows that to make yourself stronger in any way, you've had to make yourself uncomfortable. And sometimes it's downright painful, but that doesn't
Both
mean it's
mentally and
bad. You've
physically.
actually, if you've allowed yourself to recover, you've now made yourself better.
Yep.
A simple fitness thing. Um, anyways, I think I've kind of got sidetracked a little bit. Where were we going with that?
We're talking about managing, like obviously managing acute pain, but when somebody you've made, I'll pick up. You talk about two different patients. One fired you, small disc, person's back looked like absolute train wreck,
Hmm.
right? So I have a chiropractor that works in my gym that is sharing the same exact what you just said. He's like, I've seen some imaging of backs that I do not understand how this person puts their shoes on.
Hmm.
And they come in here with, a little bit of pain. They need a little manipulation. Hips are out of line or whatever.
Hmm.
Fine, on their way. You get somebody like they're walking into the gym. They look like they just got in a car wreck out front. And then he sees the imaging and mentioned, like, it's not that bad. Like, from here, it's not that bad. So it comes back to one thing I said earlier is like, there is personal interpretation of pain. But like you said, grit, pain tolerance, a lot of this is trained in how you're raised and developed. And I'm going to go ahead and say it. Our society is weak and pathetic
Hmm.
in many ways. And this it's created since what, the Industrial Revolution, when we went to technology to do everything. We're not working on farms like that 75-year-old lady.
Hmm.
Now you're in pain and the chickens still need their eggs picked up. The cow still needs to be, milked. Like this shit still has to happen. So
Hmm.
you learn grit by default because the task at hand. Nowadays, it just doesn't happen unless the only place that it happens in society now, honestly, is sports.
Hmm.
It doesn't happen in our regular daily life very much.
Hmm.
So, because the way society has evolved, we have created pretty mentally and physically weak human beings.
Hmm.
when it comes to a lot of this stuff. I was explaining to somebody the other day, it's like there's all different kinds of pain. I got something kind of hurt or achy on me all the time.
All the time.
Like there's not a day I wake up and like just I'm turning 40 soon and just like the body feels like warm butter ready to go.
Hmm.
But I've also learned over the years of training what is good pain, what's bad pain, what can I train through, and I'm going to use these terms specifically. What can I train through? What do I need to train around? What do I need to rest?
Hmm.
Like I think those three equation when it comes to both rehabilitation and training fitness, that the better you can understand those three variables when it comes to your long game of physical training is vital for you to understand about yourself.
Hmm.
Because there's a lot of times it's like if you don't learn how to train through and around injuries or understand when you need to rest an injury, you're fighting a losing battle because you can't
Hmm.
exercise the way you're supposed to exercise. You can't do activities of life, hiking, skiing, mountain biking, awesome outdoor stuff. Be a participant beyond the computer and the screen in life without the expectation that there is a constant potential of injury lurking.
Hmm.
It's
Hmm.
just fact of life. You don't know. You could roll your ankle walking off this.
Hmm.
It's just shit happens.
And one thing I want to make sure and say is I think some people listening to this are probably only hearing or interpreting that we're saying that, unless your back looks terrible on MRIs, you're basically being
Oh no
a
no
pansy.
no.
And I want to make sure people don't hear that because um, what I was referring to, and I know like what we've had conversations off of this call too, and it's like I know we're on the same page here. Um, Pain is so multifactorial,
Mhm.
and there are 80% of back pain we can't find a source on imaging. Okay. That doesn't mean that people don't have serious debilitating back pain. What I'm trying to really emphasize right now is the importance of the mindset around it.
Mhm.
If you want to overcome the back pain, we have to find a way to improve the mindset around it. Um, and I was giving those two examples because I was trying to show how one person's mindset, I do believe, really hurt his outcome. He did end up going and seeing my partner. He did get surgery. Um, he didn't have near as good of an outcome as the old lady did. Um, the old lady was like so she had I want to say a 4 level fusion. That's a pretty big fusion for someone in her 70s who lives on her own.
Yeah, there's only
She
five
spent
lumbar. There's only five lumbar joints. Four of them
so
fused.
yep. So she spent 2 days in the hospital afterwards. She went back to her farm. She's doing great. Every time I saw her in her post-op follow-up appointments, she was doing great. Um, so yeah, so the mindset's really important. And when it comes to the surgery stuff too, I'd mentioned earlier, um, like the main indications. There are some other indications more around back pain that seem to help. Um, and I guess we can kind of get more into like the surgery side of things. But so someone with chronic discogenic back pain, that often can improve with surgery if the patient's chosen correctly. When I say patient's chosen correctly, we have really confirmed that that is the source of their pain. Okay. Because if we do back surgery for that particular person and they don't get better, it turns out because like I said, we treat people, we don't treat images. Go back to the fact that we saw 100 people off the street with no back pain, 50% of them had bulging disc or degenerative disc disease. When you're looking at your own imaging, some things that you can look at on your MRI, we're talking MRI specifically right now. There are really two big things you should look at. Are any of the nerves really being pinched? I don't mean is something making contact to the nerve, but is it really being impinged? Two, do you have monsters out here? The discs, have they broken down in such a way where you're now getting the two vertebrae constantly kissing each other to the point that you can see edema in the bone? Okay, so we call modic end plate changes. Those patients, if they have classic discogenic pain, and we see those kinds of end plate changes, do get pain relief from either fusing that or from getting a disc replacement. Disc replacements versus a fusion. Um, there's lots of surgeons out there who poo-poo disc replacements. Um, I think a lot of that stems around from what they're comfortable with, what they've been trained in. But studies now comparing disc replacements to fusions show that disc replacements are the superior way to go. Reduce chance of repeat surgery, improve functional outcomes, and decrease postoperative pain. The disc replacement is the way to go. The problem with that, when we go back to looking at this, what the spine is, so we have the two vertebrae, the disc that goes in between, but remember, that's only one of the three joints. Okay, there's three joints to every level of the spine. You have where the disc is, then you have the facet joints. The facet joints are supposed to move. We need them to move a lot. Okay, not to the point of instability, but they need to be able to move. If those facet joints have a bunch of arthritis, that's a contraindication for the disc because then you have that arthritic joint now starting to grind on itself a lot. Those patients, in theory, often end up with pain. Interestingly, I have um, seen some case studies of patients with they get better. Okay, even with some of that. Um, so yeah, it's very few people. Most people who have one of those three joints going out usually have all three going out.
Okay.
So then in comes three spine. That's why they're called three spine, all three joints, because we want to address all three joints in the modus device. So now it's approached the same way as a posterior fusion, but we actually replaced all three of those joints. And the patient now has full restoration. And we've been able to, one, remove the disc causing discogenic pain. And we've also been able to remove the facet joints that could be causing facet joint pain, or if a nerve's being compressed by any three of those. And we can now address that and prevent the story of happening where every few years they're going in for the next level to be fused, the adjacent
So
level disease.
just to be clear, you just brought up the implant that you guys are in FDA trials
Mhm.
uh, with the device is called Modus. That's what he was referring to there at the end.
Yeah. So I should be clear. I am not financially tied to the company in any way. I'm I purely believe that this is just going to be something that helps revolutionize spine care, and that's our ultimate goal, is to revolutionize the way spine's done. And I think there's some major hurdles that need to be overcome with that. I shouldn't say hurdles. There's some big things we want to improve. Number one, like we were talking about earlier, the way we approach a spine patient. We don't make pain the priority. We just don't. At least I don't. So actually, I had a patient the other day. This was last week. She came in and she was just so hyper focused on her pain. The pain was the problem. The pain was I can't do this because of pain. And like I tried a little bit of like a shock and awe tactic to try and get her attention, and it worked. I was running kind of a risk knowing that I might piss her off, but it worked. And then she listened to what I had to say. I'm using a fake name here. I'll just say her name's Jen. Okay, so Jen, look, I don't give a crap about your pain, and I don't want to hear you say anything else about it. I'm not here to take care of your pain. That's not my goal. And it kind of worked for a second. Like she's like, all wide eyed, like, what do you mean you don't care about my pain? Like, I care about your quality of life. I care about your ability to move, your ability to function. I'm going to oversimplify this, but let's take this for a second. Let's take a graph. You have your y-axis and you have your x-axis, okay? On your y-axis, let's call that your pain. At the bottom, 0 pain. At the top, 10 pain. Over here on your x-axis, we have your ability to move. 0 movement. You can move 10, okay? If you live down here, or sorry, if you live over here, 10 pain, but you're not moving, okay? And there's nothing that we can physically fix with surgery. She's one of them. Then we just have to find a way to start you moving. Okay, I think we can both agree, and I was talking to the patient, we can both agree. You have a 10 out of 10 pain, but you're not moving. You have 10 out of 10 pain, but you're constantly moving and you're living life. Which one has the better quality of life? This person, right? Person who has 10 out of 10 pain but still moving. But here's the thing that I've found, and studies are also showing, there's lots of evidence to back this up. We get the 10 out of 10 pain person moving. As they progress along this, it's not a straight line over here to the 10 out of 10 movement. Their pain goes down.
Movement starts
Lots of
going.
studies show that we start getting them moving, exercising, etc., their pain improves. So I care about this axis right here. I don't want to hear you bring up your pain anymore.
Yeah.
Anymore. We're talking about your movement. We're get you moving. And they say, well, what's the answer? Physical therapy? And it's not physical therapy. Physical therapy is just the start. Like physical therapy, most people think about, oh, I go to physical therapy for 6 weeks. It didn't do anything for me.
Well, and they quit
Yeah,
afterwards.
exactly.
There's no
Or
progression beyond it.
exactly. Physical therapy is just the start with the long-term goal of get a personal trainer, go to a gym, start moving on a regular basis, start working with somebody who can take you then beyond physical therapy to life, to functioning in life. The purpose of spine surgery for us is to help people move along that action of functionality. We see something that we know will improve with spine surgery. We can improve some of this pain so they start moving.
Yep.
My wife's gonna kill me because I'm gonna brag on her for a second. Um, and I don't care about breaking HIPAA with her. She's my wife. So anyway, so I want to. She's like the perfect example. She is the dream spine patient. She had a congenital defect in her pars, basically a pars defect. So basically, that led to what we call
Just to reiterate
spondylolisthesis.
real quick, congenital means
Yeah, so she was born with this defect in the pars, which is part of the spine that helps maintain integrity of the one spine or one vertebrae sitting on top of another. So over time and with each pregnancy, she actually started to progress further and further to where one vertebrae like started to fall off of the other one. Well, as that's falling forward, the ring that's behind it's being pulled with it. Okay. So now, remember, go back to we were talking about the nerves. So that
Mm-hmm.
tunnel, the tube that the nerves are in. So now the rings here, it starts being pulled like this. So what happens there? That hole then closes. Okay.
Mm. And your spinal cord is going down the middle of that.
Yeah, well, it was below the cord first. The cord actually ends at about L1. You have your nerves hanging off of that, T12, L1. And then, so for her, it happened down at L5, S1. Okay. Um,
Jay.
Her MRI at that level was as bad as the old lady I was telling you about. Okay. She just had it at the one level, but they was so tight in there, had pulled so far over, you could not see the opening anymore at all on the nerves. Like the nerves, like there was nothing for the nerves to live in. Okay. So she was dealing with significant pain, significant weakness. It would take her 10 minutes to go to the bathroom to pee because she was losing control of her ability to empty her bladder. She needed surgery to fix the compression of the electrical cord or the electrical wires connecting the computer to what it's trying to control. Okay. She had a very big surgery for someone who's in her early 30s. Okay. So we went in through the front, reduced it, fused it, flipped her over, decompressed further, and reinforced the fusion from the back. Okay. So she's L5S1 will never move again for her. Okay. But she's only 12 weeks out from surgery. She Yesterday she got back under a barbell doing front squats. She's moving like a champ. Like she's doing dumbbell snatches. Anyone who follows my Instagram would have seen that over the last couple of weeks. Like she's doing some crazy stuff again. And she's living life and getting after it. But to her, the purpose of that surgery was not to fix her pain. It was to help her keep moving. It was to help her live her life.
Yeah, you got 4 young kids. Like,
Yeah.
and she's a
And I
very
know exactly. And everyone hearing that is going to say, well, yeah, we all just want to keep moving. Of course. But the pain gets in my way. Here's the problem. Here's the thing that I've seen watching my wife, who's a freak of nature, like just an absolute boss, okay, when it comes to pain. The pain was never her priority. Like she never once catastrophized. Yeah, sure, she was hurting, but it was her inability to like control function. to do things. So she was living up here near that 10 out of 10 pain. Her function went from here and was falling back to here. And she
Mm.
got to the point where, it's taken 10 minutes to empty her bladder. Her she was no longer able to stand up on her toes because the calves just don't work. For her, like, okay, now it's time to get surgery. And we wanted to wait because her only option was a fusion because she had such a significant drop off of that we call spondylolisthesis. She was about almost a grade three spondy. So in other words, that slipped at least 50%, almost more off of the one below it. Um, the only treatment for someone like her, even if the Modus device was available, is a fusion. So and that brings up a good point. When Modus is available and we have the lumbar disc replacements, that doesn't mean it's going to be for everybody. Fusion will probably never fully go away. But here's the thing, she's in her 30s, she's very active. That level above is going to break down at some point. That's the problem with fusions, right? That's the story with fusions. You fuse one level, 5 to 10 years later, the level above it, because all that motion translated there, it breaks down. Then you fuse that one, etc.
I was going to say, so what's happening there is once that's fused, the mobility you lost there has to be made up somewhere else.
Correct.
Now, my question with that is in active people, do you see fusions deteriorate faster because they're moving more?
Um, I I don't know that there's a solid consensus on that because
My
it's
question would
so
be is
multifactorial.
once
So
if
like the
you sorry, real quick. So I figured you'd say that there's much more involved there. What I want to get at with that is people learning how to move properly becomes much more vital because your
Mhm.
L5S1 arguably isn't a super mobile joint to begin with. Like you're
Correct.
not getting your spine rotation out of your that joint. So
Hmm.
if you learn how to move correctly, proper motor mechanics, train the proper muscles, balance, and stability, you could probably preserve that fusion for significantly longer.
In theory, yeah, you should be able to. In theory. Now, there are some things that we know increase the rate of breakdown. One of those is sitting, because
Hmm.
when we sit, we're slumped forward. As we're usually slumping forward, especially in the lumbar spine,
Zero
we're
hip engagement.
causing it to degenerate. Okay, so but then again, rowers have a very high rate of degenerative lumbar disc disease. You usually think they're always like going forward. Cyclists, same thing, because they're slumped forward trying to get in that arrow position. So I think that's probably the number one thing I know she's going to be trying to avoid.
Yeah.
And so
I
people
mean,
with the
I'll tell
fusion
my
try to
own back.
avoid that position.
I'm very mindful of the amount of time I spend on the rower these days.
Yep,
Very
same.
intentional, and I know I just did suffer camp. I spent over 4 hours on the rower, and
I probably heard afterwards.
yeah, and I expected it to hurt. Right, I knew based on the task at hand and what I needed to accomplish, this is the most time I spent in the rower. But to your point, there are things in my own life since my injury in my back that I'm very mindful of. One, quantity of doing that movement. I don't avoid the movement totally, but I'm very
Hmm.
mindful of how I'm moving in these things. I will say this over the years of working with people, a lot of times people with back injuries who are adamant and determined to overcome it and get stronger, they move the best. They end up
Yep.
being really good movers.
Take Matt Frazier,
Yep. Yeah.
fittest man in history. He overcame a huge back injury,
Yep.
and look at what he's done.
Yep.
So,
So, well,
absolutely.
all right. All right. So I think we got some good foundational information there from a medical standpoint for sure when it comes to working with, around, and steps forward.
Yeah, I kind of want to summarize and kind of clean it up so it sounds practical for someone. So, you're someone who you struggle with back problems. Okay. I think the number one thing to think about, you're going to set yourself up for success, is going to be being very, very mindful of how you view your own back problems. For one, never say, I have a bad back. Man, that might be true. Okay. but by saying it, you just really make it worse.
Hmm.
That's 100% the case. Like, quit saying, I have a bad back. Say, I have a back. And there's some things I need to improve in my back. Okay, sure, I have back pain, but I can improve it. That's number one. Number two, understand your imaging and don't marry yourself to image diagnoses. Don't marry yourself to, I have a bulging disc. I have degenerative disc disease. I like, don't marry yourself to that. I have a spondylolisthesis.
Hmm.
Don't marry yourself to that. Again, I go back to that study, 100 people over the age of 30, no back pain. Half of them have degenerative disc disease, bulging discs, spondies, etc. Lots of things go into whether or not it causes pain. Some of it is mindset, some of it is sensitivity to pain. Lots of it we don't know, and that's fine that we don't know. What we do know is control your mindset. Two, understand what you're looking at. If you see something that is injuring the electrical wires, that probably needs to be fixed at some point. Okay, and there's lots of ways those people present. Most of the time, they're not presenting with back pain. They're presenting with hip pain, leg pain. Yeah, they can have back pain, but that's not always the case. Then, if it is back pain, is it truly coming from a mechanical issue in the back, such as the disc is broken down to the point where the bones are kissing each other, you're getting modic end plate changes? Do you have a large facet joint cyst or something that could be causing some pain? Some things that we can physically see and go after. And by the way, that's where a lot of injections come in because if I go back to we treat people, we don't treat patients. I have someone come and see me for what sounds like sciatica in their left leg, and we get an MRI. They don't have any pinched nerves on the left side, but their right L5 is being pinched. Well, obviously, we can see on imaging, right L5 looks like it's being pinched, but remember I said they have no right-sided leg pain whatsoever. So for some reason, we don't understand why, that's not causing them any problems. So we don't do surgery for that. We don't even inject that. But let's say that they have left leg pain and it goes all the way down to the top of their foot, okay, or the inside of their foot. They have three nerves that are being pinched. Well, I just described one nerve going down to the top of your foot. I described L5, okay? Three nerves are pinched. One good reason to use injections is for diagnostic reasons. Let's inject each of those nerves on a different day. Let's put some lidocaine, some numbing medication in there. Does the pain go away? Awesome. Well, we just narrowed down to which level to hopefully minimize you needing now a 4-level fusion because you had three pinched nerves. We just addressed the one that's bothering you. That's one way to look at it. Um, from a therapy standpoint, injections can sometimes help with long-term outcomes by helping the person start moving, by helping control pain. The injection itself, there's no magic juice in it. Okay, we can put a little corticosteroid in there, a little numbing medication, knock down some of the inflammation, but the injection itself doesn't fix any problems. But it can help control the pain enough to get somebody moving more. So,
So I just like what he said is so important because I've had there's been many people over the years in the fitness space who have gotten injections, started moving, that allowed them to start moving, which facilitates so much good things, and then they didn't need any more injections.
mhm,
If you happen to be one of those human beings with a high pain tolerance and you get an injection and you actually have there's an injury there and you go right back to training like an, an asshole, cause more issues. So I'm speaking about myself. Sometimes you need to leave that pain to let your body heal and or to overcome the obstacle. Like my cousin just said, you treat the human. I would imagine his approach to me is going to be different than some other people
mhm,
when it comes to these things. I mean, one of my friends, an orthopedic trauma surgeon here in town, and his response to me over recent injury is like, you need to pain and stop being a dumbass. Let it actually heal, and then you'll be fine.
mhm.
It's
Yeah.
like, come on, man, can't we just inject this real quick so I can get back to business as usual? He's like, no, it actually does need to heal. So that's one of those instances of, do I train through it? Do I train around it? Do I let it rest?
Hmm.
Because of where the injury was in my shoulder, I decided to train around it and let it heal.
Hmm.
Um,
And and that goes back to like the idea of your mindset and like what pain is. Like there's good and there's bad pain, and that's learning the difference.
yep,
You broke your arm. Obviously, you're not going to go try and do a push jerk with your broken arm. It needs to heal.
yep.
Um, absolutely. And so like I wanted to finish. I kind of got sidetracked there real quick. So one, your mindset. Two, understanding and learning about like what you're looking at and what it means. Three, not marrying yourself to the diagnoses. Four, then starting to understand the process. Like say you've done all the physical therapy, done everything, you're not getting better, and so it turns out you do have something that correlates on imaging with where you're hurting. Injections can help strengthen the confidence that that is the source of your pain.
Mhm.
So you get all of that, you've gone through all that, then you start looking at surgical options. If you talk to 10 surgeons on the one problem, you're probably going to get 11 different ways to go about doing the surgery or different options to do it. Um, then making sure you're really comfortable with the team you're working with, that they're going to be a good fit for you and your long-term functional outcomes. Don't let your pain control it. You can fix someone's pain by fusing them. And sometimes that is the best answer, like the answer I gave talking about my wife. Sometimes that truly is the best and only answer. Remember, I also said a lot of surgeons will poo poo motion preserving kind of surgery, such as a lumbar disc replacement or cervical disc replacement. Interestingly, cervical disc replacements don't reimburse near as much as a cervical fusion, and it takes a lot longer to do a cervical disc replacement.
Get me
But
started on
anyways,
insurance, man. I'm about to burn that whole industry
so
to the ground.
yeah, sorry, I don't want to go down. It's a whole different podcast. But so understand your ultimate goal is your function. If you're going to keep your function going, you're going to keep your your health span, your longevity. All of that's going to go much further. Okay. Also, keep in mind that there's other technology coming out, and I think it would be a great podcast to do with Dr. Saladiki to hear more about what is Modus and what's his his philosophy on this. You've heard a lot about my philosophy, and he and I share a lot of it, but he has a very unique philosophy that I think is awesome, and that's why his patients do so incredibly well. Um, Motion preserving surgery, sometimes you just go do like a little rotor-rooter job. Just do the very minimal amount of surgery you can to take the pressure off the nerve, and those patients do well. Might they come back because it became a little bit more unstable or because, they had adjacent level disease or something? Might they come back for surgery? Yeah, they might. People with a modus or a disc replacement might also come back for other problems. But the ultimate goal is to preserve motion. Motion is life. Life is motion. A rock is not alive. Okay.
No.
Plants are alive. They move. You see them blowing in the breeze, but the more motion there is, the more life there is.
Yeah,
And
I mean, you
that's our
think
ultimate
about
goal. We care about function. We don't care about pain.
it. I mean, you think about. I think about it a lot different now, turning 40. Like my goal in my training is to preserve as much strength, stability, mobility, so I can continue to have movement and motion when my kids are having kids.
Hmm.
And for me, I'm greedy. I'm going for high functioning motion. I'm not just trying to walk. I'm trying to pull off some muscle ups at 85. You know what I'm saying? So
Hmm.
there's a whole nother podcast that we can talk about the longevity and training that way.
Hmm.
But when you see back pain, we can wrap up this episode, if you will, because I mean, we got a laundry list. This might be like a 5-part series. We actually got good stuff to talk about here. When you see people with chronic pain, I mean, back pain is $1 billion drain on our economy and medical system. It contributes to opioid addictions. I mean, back pain is a real issue in society. And I think people, and what you're starting here, is understanding one, the options. But I do think you hit on a very good point. It's the mindset around pain tolerance, the obstacles at hand can most likely, in most instances, be overcome and
hmm
have a very positive outcome.
hmm And I think that
So,
mindset, and like if we could like go back in time, there's something that I would try to have like led with because I know that there's at least with some of my patients who have heard what we've said already and they've already like tuned us out because what they've heard is, well, if I'm not mentally tough, if I have pain, I just think I'm a pussy. So whatever. And they just probably just turned it off. And I really wish like I want people to hear our mindset is everything and our mindset can grow and we can learn. I mean, that's what performance and psychotherapy is all about.
yep.
It's about so cognitive behavioral therapy, mental contrasting, mental coaching, all of this stuff. We all need it. We all
Mhm.
use it, and helping people then go from where they're at to being able to tolerate more pain. That's one of the biggest things I want people to hear. You can learn to tolerate more pain, and you can learn the difference between good and bad pain. I need people to hear that.
Yep. And you're 100% correct. And I think people need to, a big thing with people is what's the motivation, right? What's the driver to take on this adversity? What's the outcome? Some people, I hate to say it, but straight up giving up on life.
hmm
In their 40s, they're already having this conversation with themselves like my back is done. It's over. And it's very sad. It's very sad. And setting yourself up with the right team, surrounding yourself with the right people, and having I want to say a motivation. Motivation I've heard is like an inflatable backbone. It just runs out of air quite often. You need to be
hmm
inspired by something that's going to help you overcome this adversity and
hmm
work with people that are going to take you down your journey of dealing with this adversity. My journey of dealing with adversity, well, it's probably very similar to yours, but it's going to be different than Jen's path of dealing with adversity. I think of building mental fortitude as very much like building physical fitness.
hmm
There's an individual approach to take somebody from A to B. So
hmm
you're like, oh,
And
I'm
maybe
mentally.
that would be a great follow-up podcast to this. Let's talk about like what are some practical things you can do to building mental resilience. Like it is simple as making yourself do hard things, but like there's all kinds of cool stuff we could talk about from the
And to
anterior
reiterate
mixing of
hard
the
things, those
cortex and
people
things like
listening to
that.
this know the stupid shit I've done. It's not a dollar,
Yes, it is.
but it's taking what you think you're capable of accomplishing and adding a little bit more.
hmm
I have this phrase that I use in one life in coaching: you can always do one more rep.
hmm
That's life. That's an approach to life. You might not be able to do that one more rep in this moment, but if we find what we need to accomplish that rep, whatever the situation is, we'll be able to get that rep done. But we can always get one more rep done. And
hmm
just by getting that one little rep, whatever it might be, extra chapter in the book read, the little bit more of homework done, the fourth training day that week when you don't want to, like whatever it is, all of that stacks up in your toolbox of mental resilience.
hmm
So when you're dealing with chronic pain, it's like, okay, I know that I'm motivated by my outcome of being maybe not pain free, but I know that I want mobility and quality of life and to be able to do things. I don't want to be sitting, laying in a bed for the next 15 years, popping 60 Percocet a day. You
hmm
know, I want to get to here. So first you have to come up with your why. Why do I want to do it? Then you have to find your right team. Like you said,
hmm
you have to find the people that are willing to take you and support you down that journey, but also not so fixed in their ways that it's like my way or get the fuck out.
hmm
So finding the right people, and I really try to make myself and our facilities a place where we're going to listen and be a part of that journey with you. I mean, based
hmm
on a lot of our experience and years of coaching, just like all of your experience working with patients, the longer you've been doing it, the more you've seen it. If you're in my mind, an intelligent person, you know that there's not one right answer working with a human being. They're all
Hmm.
different.
Yep.
And you have to be able to articulate and work with a human being down that path of both building mental fortitude and problem solving when it comes to overcoming strength training, developing
Hmm.
all this stuff. So yeah,
Hmm.
great stuff. Cuz I think we got a good block there that people might find interesting in the next follow-ups on this, because we can talk about spine health and fitness. We can talk about both of you, me and you, go back and forth on, from zero person who's done no movement, no strength training, ideas on where to start, to the athlete on some more
Hmm.
experienced things. I really want to get into the topic with you of this conversation around stronger cores.
Yeah.
Like, just kind of nod my head when, oh, doctor said I need to get a stronger core. Did he tell you what?
Hmm.
Because the assumption in society is stronger ab muscles, which is super important. We can talk, we'll get into the anatomy of how your erector spinae, all of your different layers of abdominal muscles, your hips, how your balance in your leg muscles, the deviations between your hamstrings and quads functioning, pulling on your pelvis. Like, there's so much to unpack there that at the end of the
Hmm.
day, just training and moving properly strengthens you appropriately. Um, I think that'd be a great follow up on the next one, so we can talk about fitness and spine health, strength training principles around spine health.
Hmm.
See if any questions come up on the surgical stuff that we can follow up on. If members going through things in my community or in your life come up, we can follow up
Hmm.
on. We can talk
Okay.
about, well, pain management, which we've already kind of talked about,
Hmm.
but in really focusing on the quality of life equation. Um, I think you should get into more details in a future one, probably post surgery recovery, like what you're seeing
Yep.
in your post surgery patients.
Hmm. Yeah, we can
So,
definitely do that. Actually, so when it comes to post-surgery, there's not a lot of great evidence on exactly how to approach um, a post-surgical spine patient, and a lot of it's conflicting. Um, we're actually using our dream patient, my wife, um, as a model, and we're writing spine programs. Hers will be specific to post fusion, but then we're going to be writing some for post non-fusion, and we're going to try and publish those um, and see how we can come up with something that's best for each individual surgery, because it's not going to be one program fits all. You got to individualize to the person and to the surgery. Both those things have to come together.
yeah. I think what you guys create is a framework of, here's where we're starting, but then you need to look at the whole anatomy of the human, what their muscles are like, what their activities are like, and I think you guys come up with really some cool framework there for people
Hmm.
like me to work with it.
Yeah.
When we get somebody post physical therapy, post surgery back into the gym, that kind of stuff for me gives me a great framework to understand and work within, obviously my scope, but the goal is getting people chronic pain. If they have to have surgery, cool. If not, but getting them back to optimum quality of life. And
Yep.
that equation involves all of us. And so I think that'd be rad to see that framework you guys are building and be a part of that.
Heck yeah. Let's definitely chat about it more. Um, Man, thanks so much for having me on here, because I really appreciate it. So,
Yeah, I just
looking,
know we could go probably 4 hours on this topic. So
yeah,
I
let's
got,
break it up. We'll talk more about other stuff next time. And I'd say if there are three things I hope anyone got from this, number one, it's be mindful of your mindset. Two, don't marry yourself to a diagnosis. And three, understand what your imaging actually means. And I guess that's four things. Once you understand what your imaging actually means, the number four, learn and understand the process and get yourself involved with a team that has function and has you in mind, and it's not just your pain. Someone who's treating more than your pain.
Yep. And I want to just you to reiterate on something. Understanding your imaging. By default, people think, do I need to like search Google and like look this up? I assume that you're meaning making sure you're having good conversation with your
Yeah.
surgeon, with your doctor about what this all means and all the possibilities related to said imaging.
Yes, exactly.
Right?
Because
Not
at the end
put
of the
on my
day, they
chart,
have to
my
be
chart
treating a
shows,
person.
yeah,
Yep. Treating a
my
person,
chart
not
shows
treating
my
an
imaging.
image.
I'm over here on Google trying to find some shit. Like, no, that's not what we're saying.
Yep. Go over your imaging with your surgeon, your provider, whoever's going to be. Make sure it one matches where your symptoms are. You're not just treating findings on an image. And then two, make sure that unless it's something that you're having true functional deficits, you have truly given yourself time and the ability to overcome that from a non-surgery standpoint, especially if what you're truly looking at is a fusion is your option. And for some people, that really is. You want to try and go as long as you can before you do the fusion.
Cool. Yeah, I think we can get into a follow up episode too. I could just take you through my back injury in detail. That'd be a good one that we can do, and talking about how I rehabbed myself. I
Hmm.
did it all myself, and probably could have sped it up working with somebody else, but you know, you know how it
She
is.
also learned.
Yeah, I learned. Right
Yeah. Yeah.
on, cuz. Love you, man. And
Love you too.
we'll get questions, and I'll hear the feedback in the gym, what people are saying, and we'll do it. We'll hit a follow up on this because this is good stuff.
Awesome. Thanks so much for having me, man. Looking forward to next time.
Love you, bro.
Love you too.